Welcome to Peds Pharmacology Part 2. This lecture addresses all of the drug pharmacokinetics and metabolism, so it's going to be longer than the others. We have learned to be careful with children because of past disasters that have occurred. When we gave sulfonamides to children, they developed a dangerous condition called kernicterus, which caused permanent harm to the brain. Chloramphenicol caused them to have a gray skin, and we called that gray baby syndrome. Tetracycline, when it's given to children prior to erupting secondary teeth, causes permanent teeth discoloration of those secondary teeth. Only 20% of the prescription drugs that are on the market at this time have pediatric dosage recommendations that's actually based on research. So there are physiologic differences that occur in children that must be kept in mind when we're giving medications. So oral medications are affected by the gastric acidity, similar to that of adults. Well, in a child that's less than age 2, they have less acid in the stomach. They also have frequent feedings that alter acidity and the alkalinity of the stomach. Therefore, it changes the absorption potential. Gastric acid secretion is quite slow in the premature infant, and it can take up to 4 days for them to develop the normal levels, and even that is less than what it is in an adult. Their gastric emptying time is prolonged in the first few days of life, and then it becomes quite rapid. They also have very slow peristalsis in their gut. So the emptying time of the stomach is intermittent and unpredictable in an infant, and then it slows as they become more mature into their toddlerhood, preschool, etc. And keep in mind that slower peristalsis means that there's greater absorption in the gut. Pancreatic enzymes are variable in the infant until they're 3 months of age, and this may affect drug metabolism. Keep in mind that when a child has a diarrhea-type illness, it lessens the absorption of oral medications, and therefore we're going to see a lesser therapeutic effect. When we look at injectable medications, there is a decrease in blood flow at the site of the administration site, especially in the neonates. They have variability not only in the blood flow, but they also have very low muscle mass in comparison to older children, and it can lead to delayed or variable absorption. We give very few medications IM or sub-Q. Primarily, we're giving immunizations via that route. Infants have a very high metabolic rate, as do toddlers and preschoolers. Don't you wish you had that metabolic rate that you had when you were a kid? You could eat anything and do anything, and you never had to worry. Body fluid content of infants and children is very different from that of adults. Infants are 75% water. Younger children are 60% water. And therefore, we need higher dosage of water-soluble drugs in order for us to reach the therapeutic level that is desired to have the effect. And vice versa, if a child comes in dehydrated, then water-soluble medication dosages are going to be adjusted because they're going to be extremely concentrated in a kid who is low in fluids. We have to be very careful when we're giving fluids to a child because the cardiovascular system cannot accommodate it, and you're going to see side effects much sooner in a young child and an infant than you would in an adult. Their muscle mass is only 25% of their weight versus in an adult it's 40%. When you're giving topical medications, you have to remember that the infant has a very large surface area that affects the absorption of those topical drugs. And they absorb meds through the skin 3 times more than that of adults because of this large body surface area. Their body fat is going to change, and it varies with age, and therefore fat-soluble medication dosages may differ. We don't make a huge adjustment based on body fat unless it's something like a chemo drug, or others that say to if you have an obese person that you have to dose them on their desired body weight, not their actual. Infants have lower plasma proteins, and when you could think about drugs being protein bound, the stuff that's protein bound isn't being used. It's the free drug that's being used. So if an infant is given a drug that's supposed to be highly protein bound and they have lesser proteins, that means they have higher amount of the free drug that's circulating, exerting its effect, and that increases the potential for side effects. Another very important thing that you must remember is that the blood-brain barrier is not mature until age 2. It's far less selective. And so when you look up a drug and it says it has the potential for neurotoxicity, we worry about this in a baby that's less than 2 because this drug is going to go straight up to the brain. It doesn't have that barrier like you and I have. Also, because these kids have an immature neurologic system, drugs that we normally would give to sedate an adult will have the opposite effect of a child. You can give something like chloral hydrate to a child, and it seems like it's such a large dose, and the kid is still awake, and that's because they have an immature neurologic system. When we look at the metabolism of drugs, so remember, we have absorption, distribution, and then we have the metabolism where we're breaking it down so that we can excrete it. Well, infants have immature livers, and so they do not metabolize drugs the way you and I would. And then as they become a toddler and into their preschool age, their livers are actually quite active and they're going to metabolize drugs a little bit quicker. So these are just things to keep in mind. And then last but not least, we have excretion. And the infants and the neonates are, remember, the first 28 days of life, they have a decrease in the GFR. It's only 30 to 50% of adult level. And then they become the standard GFR after age 1 year. And so if they can't excrete the drugs, then there's a higher risk of toxic blood levels accumulating. And the same can be true if a child is dehydrated. So in addition to having a decrease in the GFR and not able to excrete, and then you couple that with the decrease in the fluid volume that is circulating, that's also going to increase the toxic blood levels. So this ends part 2 of Peds pharmacology. Move on to part 3.